I think last but not the least, we have another senior plastic surgeon, Professor Narayan Murthy. Needs no introduction. I think I've been waiting to listen to this. Diabetic foot ulcers, offloading, flap surgery, nerve release. Are we spoiled for choice? Over to Dr. Narayan Murthy.
I think Dr. Ravi Kumar Chichori, I think as the other side, I think I'm indebted to tell you that he is one of the recipients of a very prestigious award. I don't know how many of you know about that award. There's an award called the BMJ Oscars, which is a very prestigious award awarded by the British Medical Journal in India. So that is for novel and innovative ideas, and he is one of the first recipients of this award by the BMJ India chapter, and it's called the BMJ Oscar Awards. He's one of them. There are another 4 or 5 of them, and we are very proud that he has made everything so simple. Thank you very much, Dr. Ravi. So the fag end of this session, let me see how interesting or stimulating I can make it. As you all know that there are 3 options when you have an ulcer as far as the diabetic foot is concerned, and I tried to put my experience over the last 20 years to see what I do over these years. I'm also a professor at the biomedical engineering department, so that gives me an additional insight into innovation, research and things like that, and I'll share with you very quickly of some of the things I have done. Now, as far as the global perspective is concerned, we talk about offloading. There are several data, and this is one of the things we said there's no data to examine the effectiveness of footwear in ulcer, and we needed longitudinal studies. This was reported in the Journal of Diabetes Complications 2013. However, there is one study which says that orthotic therapy reduces the plantar pressures and usually is useful. Let us come to see what the Indian perspective is. So this is what we see. This is the ground reality. There are a lot of people who walk barefooted, especially during festival times. They go through the rough terrain, and because of the social custom, you can see that there's a board saying do not wear footwear. So as a social custom, we all walk barefooted, and this compounds the problem of injuries to the foot in diabetic patients. This is another sad state of affairs. You know, we can sit in a private hospital and talk about offloading, but this is the ground reality where everyday people actually go like this. You can see this contraption as a footwear in these patients. If he is a diabetic, you can see what will happen to this patient. Now, the only study we had from India was this on the effectiveness of the different footwear, and it does show that there is a increased protection to the feet if you wear at least some footwear. There are other things from another person who again does a lot of original work. Very simple contraption, just to add a small wedge to offload this, and this will heal. You can also use this. It's called the Mandakini device. All you do is it's a glove wrapped up with a small tape, and then this actually offloads this. Very, very easy, cheap and reproducible technique. There are other things, the molded for diabetic footwear available. It's just for completion. There are other people who do it in a very mass scale. My personal experience I'd like to talk about here. This is my first patient actually when I came back in 1994. She's the ideal patient who had this chronic ulcer. As I told you yesterday, we did a flap. She healed only to come back in 6 months' time, because at that time we did not have a proper footwear to offload this patient. This again, when you talk about offloading and flaps and reconstruction, we need to know which group of patients we are talking about. So quickly, just to go through, the time of presentation when the patient comes to is important, and I classify according to how long the duration of the ulcer has been when the patient comes to you. So this is something, as you know, patient comes within the first few days to few weeks. You debride them properly. This is again acute infection. As you can see, you can do local flaps to conserve the, as you can see here, the MTP joint is exposed. and you can do a flap to reconstruct so that the patient can actually even have the grade 2 back. Here all the metatarsal heads have been covered with a free flap, and you get a mechanically okay foot here. This is when the patient comes to you when this ulcer has been there for quite some time, more than 6 to 8 weeks or 13 weeks. I call them subacute, and again there is a problem underneath. Unless you take care of this, this is not going to heal. The moment you release it, you can see that this is closed primarily. In 5 days time when the patient comes, this is healed. Now this is what we are talking about. When you are talking about flaps, offloading, nerve surgeries and various surgical procedures you are talking about, this is the group I am talking about, which is actually labeled as chronic infection, or you can call it chronic non-infective non-healing wounds. Usually these things are there between more than 6 months. They can belong to any other grade of the UTS classification. The thing is, they are potential for infections. These are other chronic infections. As you can see, you have to debride them, find out there is a large cavity and close. So whenever I talk about this is what I want to talk about. So potentially infected, recurrent infection, the aim is to close the defect, and main thing is to make sure that the wound what you had reconstructed remains healed in that way. So this to show how we did this, and she came back. So this is again a chronic infection, only feet she had. So she had osteomyelitis, debrided extensively, did a flap, and then she healed. So what I want to talk to you about is offloading. As you see that the complications following any of the reconstructions is because of pressure. This patient had an ulcer, she had a free flap there, and you can see that just within 6 months she developed an ulcer exactly where she had an ulcer. She had a lateral arm flap, but she developed an ulcer there. So what we did was to develop some system to quantify. So unless like a renal function test or liver function test, a cardio function test, I wanted to develop some system where you can develop a foot function tests. So for which what we did was to look at the pressures. As you can see here, in 2006 or in 1998, we developed a new pressure parameter where the pressure is measured when the patient stands on this. This is the pedopograph. We measure the pressures, which was published in 2004 in the Journal of Engineering and Medicine, and we found that it's a very accurate method of measuring the pressure in the sole of the foot. So after reconstructing, it's very important that you find out the pressure points so that these things don't recur. You also had to quantify the hardness of the callus, and we use that calling Shore meter, and you can see that diabetic patients have a much thicker and a harder sole compared to the normal people because of glycosylation. And we also know that whenever a patient insensate skin, there's a normal patient with callus, but when you shave it, there's no ulcer. This patient has got callus, and when you shave it, you know that there's an ulcer in an insensate feet. Okay, so what I wanted to do was to classify this. Okay, this I call it as a stressed foot, this is a failed foot, and this is a hypertrophic well compensated foot based on how to measure them. And what we did was to have, as you can see here, this patient we measured the pressures, we also measured the hardness, and we developed an index called the PRS index, and this is before the patient had the offloading device. This is after offloading. You can see that after 6 months the PRS index, or what you can call the foot function test, from 225 has come to 144. Footwear we developed our own, and this is based on various studies. I am not going to the details. We looked at various materials, the hardness, the thickness, and various properties, and we found that the best was to have a single layer. There is no need to have multiple layers. All you have to do is a single layer MCR device, which is about 9 millimeters, that will actually give you 60% reduction in the vertical stresses in the footwear. So we devised the pressure measurement system, we measured the footwear. And again we found that if you give that footwear in 6 months time, the diabetic patients with footwear, with our recommended footwear, the pressure actually comes down to normal, and this was published again 2004. So when the patient wears this footwear, and then you can measure this, and you can see that the pressure of these patients here is becoming towards normal, and I would call it primary prevention, because if this footwear can reduce the pressure of these patients, you can be sure that this patient is not going to develop ulceration, because high pressure is going to translate into ulcer in these patients. So when you can document these patients having lesser pressures, I call them primary prevention. If the patient has already got an ulcer, then we give them this footwear with a small rocker here, and you can see that the patient has been walking, and the area where you want to offload is offloaded excellently. You can see the patient is walking and this area has become dirty, and this area where the patient, where you don't want pressure, is actually offloaded, and this will go ahead and heal. This is another patient. As you can see, this patient had reconstruction with the vessels, with the local flaps, and we offloaded it. The point is, she came back with the other look because she developed chalk-closed foot and a small ulceration. So this I'll tell you what we did later. That same patient we had here, as you can see here, this patient had this ulcer there. We took the pressures, offloaded, and you find that the pressures of the patient actually healed, but you had to monitor them so that the new pressures don't come. This is the first patient. As you can see, we reoperated, gave them the footwear, and you can see that for more than 13 years, she never re-ulcerated. And you can see the impression of the foot. You wanted offloading in the area where the ulcer was, very successfully offloaded with this footwear. So this is, we published in 2008, I think, and then in the European Journal of Plastic Surgery. So if you can keep the pressures low, you can offload. If you can get the proper footwear and measure them regularly, keep the pressures low, then you can be successful in saying that you are decreasing the pressures in these patients. So this is what happens. You get an image of this image of in a pedograph. There's an algorithm which will tell you they look same, but the algorithm will show you that there's a diabetic patient with a high pressure, and you give them footwear, follow them up, you offload them, they'll get better. So that's about offloading. So we looked at offloading. Whatever you do to the footwear, whatever you do to the patient, make sure that you surveillance them, check them, make sure the pressures are down, are kept below, then you will be successful. Now the next thing I said was we need to look at offloading, flap surgery and nerve surgery. Now going back to the principles of plastic surgery, which is like with like, this patient is actually a normal patient. He's a young fellow, got a motorcycle accident. We put a skin graft here because he has severe degloving. Part of the heel was lost. So this is what happens to skin. Happens to, yesterday I think people are talking about what skin to use in the sole of the foot. A split skin graft will actually a bad choice because this is what happens to them. So you want to actually give them a sensate plantar skin, and this is what we did here. If you see this, sorry, I'll come to that later. This again is another example of a patient who loses in trauma or various situations, they lose the plantar skin. Our policy to use is to use actually the plantar skin as a graft, and you can see that the plantar skin used here, it looks bad initially, but in 6 months time you will hardly notice any difference. They don't hypertrophy, they don't have eczematous changes, and they are very well changed. This is again another patient who had a diabetic foot ulcer, extensively debrided. This is again a plantar skin taken from the other side, and you can see that there is no hyperkeratosis there. So the message here is that if you can put a plantar skin on the plantar side, it is much better to take care of the stresses which the plantar side actually experiences. This is another example of a patient where you can see this patient had a melanoma. We did a medial plantar flap here, and you can see that beautifully this is incorporated. You can also see that this skin which has come from here and sensate is beautifully demarcated into the load bearing and the non-load bearing glabrous skin. Imagine if you had put skin graft here, this would have looked like this. I would rather have a split skin graft here than here. Now coming back to this again, this patient had this severe problem, recurrent infection, hyperkeratosis and whatever. We planned to do this medial plantar flap, this flap which is sensate with a normal plantar skin was placed here. 7 days you can see that this skin has nicely healed. This is also incorporated, and about 3 months you can see this nicely healing together, and in about 2 years excellent formation. You can see that this is beautifully healed, and this again will have recurrent problems of hyperkeratosis, but it doesn't matter. Now coming to I talked about flaps, I talked about this thing. Coming to the ulcers again and high pressures. We found that if you can decompress the nerve, okay, the root cause of every problem in diabetic foot is neuropathy. And if you can reverse the neuropathy, all the problems which can happen, like ulceration, hyperkeratosis, infection, and acute limb injury, infection, and sometimes death can be avoided. So the problem was how to quantify and how to do it. So what we did was, we took the pressures of these patients. You can see there is callus formation, increased pressure. We release the nerve, and you can find that the patient's pressures come back to normal. So that shows that if you can bring back the sensation, you can treat everything. Again, if you see, there are people with flat feet, with rheumatoid arthritis, with multiple deformities, calluses, in non-diabetics where have normal sensation. They never ulcerate. You have rheumatoid patients with severe deformities. They have small calluses, but they never ulcerate. The moment you have a deformity, the moment you have a callosity, and you have neuropathy, it will ulcerate. So the idea was to see whether we can reverse the nerve so that we can look at it. Okay, these are some of the examples. This patient had nerve release on the left side. He went on a long pilgrimage. He came with a burn on the right side, but left side is absolutely normal. Okay, so if you can reverse the nerve, you can actually prevent acute infection, acute damage to the skin. You can also prevent chronic damage to the skin. Another example of a patient where he had release of nerve on one side. The problem in India is they don't come back. They come back later with problems. So this patient had release on one side, never came back for release on the right side, but that came back with the complications of infections on the right side. Now, I do what's called component evaluation. You had to look at the bones, the skin, vascular, and the neuropathy. This patient, as you can see, he may have a small ulcer, but he's got that hypercallosity. You get an X-ray, you find that the right foot is normal. Right foot, this is the right foot. Right foot is normal. The left, he's got early collapse of the midfoot, which is translated into high pressures in the MTP, and he's developing early ulceration there. What we found is, you can do so many things, but if you can reverse the thing, this patient had a tarsal tunnel release and sensation was coming back. It's very surprising to see that the hypercallosity or the hypertrophy of the ball of the foot was also decreasing, and the ulcer is healing. So in these patients, you had to decide, are you going to offload, or are you going to do bone surgery, or are you going to do nerve release? If you can do nerve release and restore the nerve sensation, other things it probably doesn't matter. Another example, as you can see here, this patient has got collapse. This is the varied distribution of a sensation. As you can see, it is not, most of these patients do not have glove and stocking as they are classically told. They are very varied. And if you can release and this patient develops sensation back, then this is another example. As you can see here, huge ulcer. What will you do? Will you operate, do a flap, give her a footwear, or do a nerve release? We know that if you give them footwear, they don't actually wear it very often. You cannot do nerve surgeries because they may not wear footwear. The idea is, if you can release the nerve and get the sensation back, as you can see here, this patient had released the nerve. Over time, this callus just fell off, and then the ulcer was healed. I took this picture because, as you can see, in a normal situation, when you release the nerve is just in one big fascicle. But this nerve was badly damaged, and you can see that the nerve was actually in different fascicles. Even then, this patient actually restored sensation, and then she was okay. As you can see here, the ulcer healed. She was actually coming back. And whether will you give footwear? I think footwear is still important, but at least now that the wound is healed, the nerve sensation is gone back. Even if she doesn't wear footwear for a short time, they actually are okay. But you have to tell them that they need footwear. This is another classic case. As you can see, large, very large ulcer, got healed. We did a nerve release on the right side. It did not come back, came back with an ulcer on the left side. As you can see, this large healed wound. So right side, nothing happened. He came back with an ulcer on the left side, and then we did a tarsal tunnel release on the left side. Some of these patients do have increased complications of wound healing, but you can see that this wound, right side never had ulcers, left side just about healing. Okay, can you see the right side no problems, left side just healing and in the process of healing. Another classical patient, as you can see here, diabetic neuropathy, has multiple ulcers, keeps on coming, does not wear footwear. So what will you do? Release the nerve. This is dramatic because we released the nerve on a Friday and the patient came running on a Monday, because normally I see them only a week later. Because on a Sunday what happened was he had a rat bite. Can you see this? He had a chunk of toe bitten off. My feeling is that the rat had actually tried to eat because the blood it came here, tried to eat the left toe, but he would have kicked it out because he got the sensation back. But the right side, he lost the toe. Now this is one of my oldest patients, as I showed you before. We did a flap surgery. She was doing extremely well, but 10 to 15 years ago, I was not doing nerve surgery. But I had the opportunity to follow her up for more than 15 years. This is one of the things I showed you. You can see that the flap is nicely healed. She never re-ulcerated, but she's, as you can see here, over time, she's got all the features of neuropathy. She's got auto amputations, she's got infections and things like that, but the flap is healed well. So I was thinking, if I had only done her nerve release at the time, 10, 15 years ago, she would have probably been okay. Or she wouldn't have developed the Charcot's foot on the left side, but we did not do it at the time. So what is it? What I want to tell you is, please look at neuropathy if it can be reversed. It is not possible in all the patients. We know that in diabetic patients there is neuropathy, there is a loss of sensation, which is the reason for every complication which happens in the foot, including progression of Charcot's foot, ulcer formation, and we all think that footwear is a very important thing. So conventionally we think the nerve is not reversible. Footwear is the important thing in an ulcer, but please do consider that nerves can be reversed, and if the patient gets back the sensation, everything will be okay. In an Indian perspective, there's a huge thing to think about. So in the end, I would like to say, if you don't feel and if you can make it feel, that's the solution. Think of nerve regeneration. Footwear is a very important adjunct to the management of these patients, even after release the nerves. Flap is to fill a hole, and if you want to fill a hole, make sure you use a sensate flap, not just an insensate flap. Thank you.
Thank you, Professor Narayan Murthy. You've kept us all looking onto your slides. Interesting. We've been all awake. We are not sleeping still. To just keep the ball rolling, one personal question that I would want to ask is, it is a well-described procedure in the literature that releasing the nerve in the area of anatomic narrowing, or when the tarsal tunnel in those described areas of narrowing, it may do a benefit. But when the patient really doesn't have as such a tarsal tunnel syndrome kind of thing, where the anatomic narrowing of the nerve cannot be demonstrated, still would the technique work?
See, the big question is, because we have to justify what we do. We have to actually justify a nerve release based on evidence to actually diagnose narrowing at the tarsal tunnel, and the gold standard is supposed to be nerve conduction study. Lee Dillon has also done, has mentioned in his recent paper, that even in normal people, the nerve conduction is fallacious or wrong in about 50 to 60% of patients. And my experience in India is that nobody can interpret the nerve conduction study. So we are left with a condition where there is a huge problem. Nerve conduction is supposed to be the gold standard, but literature as recent as this year is not very conclusive. So we need to devise other techniques. So what we did was, I have not mentioned here, is we developed another system called the law of mobility, where what happens is, the law of mobility states the sensation of the part which is furthest away is more than the sensation in the part which is previously. So the sensation in the tip of the toe will be more than the sensation in the heel, and the sensation in the heel will be more than the sensation in the just above the ankle. So we devised what is called a law of mobility, where we record the biaesthesiometer or the vibration pressure in the just above the ankle, in the heel, in the midfoot, ball of the foot, and the big toe. So normally we will find that in normal people, the ball of the big toe will be around 15 to 8 or 10. The ankle will be about 20, right? And the big toe may be about 8 or 5. So when you draw a curve, it will actually go like this. We found that in diabetics, we call it as law of mobility is reversed. It reversed because what happens is your medial malleolus, the VPT will be 25 or something, and a ball of the big toe will be 30, and the tip of the big toe will be 40. So this reverses, and this has been published in articles in 2010 actually. So we follow that system. What we do is we map out the sensation from the proximal to distal, and if the sensation of the big toe is less than the sensation of the ankle, that's suggestive of compression of the ankle. If the patient has got complete loss of nerve, which I think like a typical what they have been described as a glove and stockings, then you should have it in a straightforward manner. That usually doesn't happen. So what I do is we plot the nerve of the law of mobility, and if the law of mobility is not obeyed, then we subject them to the nerve decompression. That is one. Second thing is, more importantly, we are talking about, we only test sensation. This is again anecdotal, my own personal experience. What we found, but it is well recognized that in carpal tunnel syndrome, the wasting of the abductor pollicis happens before the loss of sensation. And we found that in clinical practice, you can actually, I will show you some slides where the abductor hallucis of the toe or the foot actually wastes when the patient has got burning and other positive symptoms. So this again we may publish it later, we are just getting this data. So the initial impression is that when the patient has got compression and he's got pain because of the compression, what is happening is the patient is crying out for the pain relief, but what is happening is the muscle is actually wasting. So if you find the patient has got positive symptoms and the muscle is wasted, there is a good possibility that these people regenerate if you release the nerve.
Sir, I have one question. We know that we have got thick skin in both palm and sole. When you take a graft from the palm itself in a non-weight bearing region, do you take a full thickness
or a
partial thickness?
Yeah, it's slightly more difficult in the palm and the hand because it's very easily you'll take a very thin skin which just becomes a superficial layer which becomes very dry. So you have to take the right amount of thickness. It should not become too thick. Then if you do that, then the donor area.
What is the technique, sir? What is the technique you use for it?
I think just you learn it. That's all. I can't tell you how it is, but make sure it has happened to me. When you start taking very thin skin, you'll be very surprised that it just looks papery thin and it's actually dead. So what you do then is keep that separately. Take another slice. Use this slice to cover the previous one.
And in the donor side, do you use any SSG or you just leave it?
No, leave it. If you are not taken the full thickness, if you are taken the right amount of partial thickness plantar skin, it will regenerate.
Thank you.
So my policy is to use only plantar skin for all plantar defects, and you can actually put it on even larger wounds. You will find that hyperkeratosis, changes, eczema, nothing happens, and cosmetically it looks good.
Like replaces the right like.
Like with like, that's the basic principle of plastics.
May I invite a few comments from the other side of the Atlantic regarding nerve release?
Yeah, I'm curious, Dr. Murthy, I enjoyed the presentation. We really strongly embrace the nerve release for painful neuropathy, and you've done a lot of work in the sensory restoration. Have you found, get your patients 5-10 years out, do they need a repeat release? Does this recontract? Do you get restenosis around the nerve?
See, I started with doing this for pain relief, and I can't tell you we have enough follow-up because that's a big problem for us in India. But so far people have not come back saying that they have actually recurred the symptoms. What I am doing is to see whether, you can see I have not shown some of the pictures, people who have established long standing ulcers you put them on a total contact cast, heal the ulcer, and then do a nerve release, and they don't recur. So there are three indications. One is symptomatic relief of pain, which is well established and all the patients are very happy. It is exactly like a carpal tunnel. You release them in the evening, next day they sleep. There is no problem. So that is for pain. The second thing is you are talking about releasing this nerve to restore sensation in supposedly people who have lost all nerve function. Because if you have an ulcer, usually you say that the patient has got no sensation, but they do have some sensation. And I think it is not an all or none law where the nerve is dead completely. There is always a regeneration and degeneration going on. It just depends on how much you can regenerate in a degenerating nerve. And we found that in ulcers, established ulcers, all those patients you saw, they have established ulcers. They have no sensation. But you'll find that after you heal the ulcers by any means, either flap surgery or nerve release, flap surgery or just total contact casting and or the footwear, if you release the nerve, they slowly get back the sensation and they don't re-ulcer.
And on the plantar grafting, if you take a thick glabrous skin graft from the plantar, do you ever go ahead and replace that with either a artificial tissue or a thin graft from the thigh? Would you replace that, or you just leave it?
Actually, I don't use any of these skin substitutes. It may be a good idea. During the early stages, this is the problem. When you take an early stage, you actually take it too thin, and then the too thin skin is actually useless because it's just completely dry. But I don't throw it away. I just keep it so that I take a next shave, and if that shave is deeper, I use this to put it back. And I never had the chance to use a secondary split skin as non-glabrous skin on the plantar surface. We have had deeper skin grafts where the skin actually becomes hypertrophic, but they don't become keloid. They do hypertrophy, and then we manage them with pressure garments and things like that. So we have actually taken large areas of skin and then put them, and then you'll be surprised to see that the plantar skin just behaves like a plantar skin. And you can see that if in the medial plantar flap, I would rather have a skin graft taken from the thigh on the medial side rather than on the heel, because heel just beautifully heals. The question is whether the biggest dilemma which I face in a patient here, the flaps we put in, they are sensate flaps, and the glabrous skin, and then the plantar skin you are putting is again on an insensate area. Is it the skin alone which is protective, or is there sensation back? I don't know. That's another big question. Is just the plantar skin protective, or does it develop sensation? I don't know. So they're all just observations.
Thank you very much, Dr. Narayan.
I have one more question, sir.
Last question.
Sir, actually by nerve release, you mean to increase the axoplasmic flow?
No, see, what happens is, now again, see, these are all my own clinical observations because there's no literature. If you see the literature, there are a lot of things on the medical side. They classify extensively, saying that the patient has got mono, single nerve, or systemic, bilateral, glove and stocking type. Okay, what I do now over the last few years, what I do is, I can ask in the audience if anybody has done complete full nerve examination. I don't think they do. What I do now is when the patient comes, I examine the plantar area and look for thickening. Look for the other side, look for thickening of the nerve. And actually, if you see for thickening of the nerves in the ulnar, and if the patient has got thickening of all the palpable nerves, I think you are dealing with a different problem. If you have nerves, a symptomatic foot, you will find that most of these patients will not have as much of a thickened nerve as patients sometimes who have no sensation but have thickened nerves, like leprosy. So clinically, I'm still learning. So clinically, you'll have to find out who belongs. But I don't think anybody does full clinical examination, either neurologists or diabetologists or anybody. But you have it in textbooks saying that these are different types of neuropathies.
And does it improve the microcirculation as well, sir? Your technique, your special technique.
I'll tell you what happens. When you release the nerve actually pops up, which I infer that it has been under pressure. And I would think that it will actually improve the either lymphatic or venous or microcirculation. But I mean, I've not done anything to document what it does, but only thing is symptomatically they just get better. The ulcers don't recur. And they go through a phase where there is hyperesthesia. They actually become extremely sensitive for a few days, then they get better.
Thank you very much, sir. I think over lunch we can discuss it more with Dr. Narayan Murthy.
Thank
I'll
you.
ask you to just stay back and give the token of memento to our vascular surgeon, Dr. Rajarajan Venkatesan, who was the speaker for the last session.